With different pan.
Conference record has joined the conference.
Good morning.
Good morning. Is that Ken?
Good morning, Ken. This is Dr. Schulz.
This is Chuck Schulz. Nice
Good
to
morning.
nice to talk to you.
Nice to talk to you. Thank you for joining us. Couple things. Has anybody introduced themselves to you on the phone?
Not yet.
Okay, great. So, good morning. Let me just start by saying this is Dr. Ken Duckworth. Thank you for joining the Friday call. We are recording this call, which you can access at www.nami.org/askthedoctor if you don't happen to be free at 10 o'clock Central Time, which is where Dr. Schulz is working. I thought before Dr. Schulz would start, if you were comfortable unmuting yourself and just saying your first name and where you're from, so Dr. Schulz has a little bit of a sense of where who he's talking to, appreciating that not everyone will volunteer that. So *6 mutes you, which is the best way to do these calls. #6 unmutes you. But I like our guests to have some sense of who's on the call. So if a few of you would just sing out who you are, where you're from, first names only preferably because it's being recorded, that would be nice for our expert today.
Becky from Iowa.
Andrea in Minnesota.
Nancy from Wisconsin. Becky
Wisconsin?
from
Lisa from Pennsylvania.
Ruth from Vermont. Dallas. Doris from Florida. Lori from Scottsdale, Arizona.
Amy from California.
Becky from Nashville. Could you go over the muting instructions one more time, please?
Yes, thank you. So the voices there, Dr. Schulz, illustrate the complexity of running a super low-tech phone call because we can't order them. But you get a sense that we're covering a lot of people in a lot of different places. I just wanted you to have a sense of the reach of the call. *6 on this call mutes you. So you can do another task. You can have a barking dog. You can do your dishes while you're listening. It's all fine. And if you have a question after our guest today gives a 15 or 20-minute summary of the work he's doing and the topic, you can hit #6. That will unmute you. You can ask a question and then go back to *6. I'm very grateful for those of you muting yourself. It helps us improve the quality of the recording. So when you go online, if you're interested in the topic, the quality of audio is a little better. Well, Dr. Schulz is our expert today. He's a longtime friend of NAMI and has really been a leader in a couple of areas, the care of people living with schizophrenia. And today's talk is early onset schizophrenia and some early intervention work. And he's also developed a lot of expertise in borderline personality disorder. And these are two areas that are important to the NAMI membership. And he's a professor at the University of Minnesota School of Medicine, and really is a wonderful friend to NAMI. So without further ado, I could do your whole CV, Dr. Schulz, but we only have an hour, right? So I'm just going to do the briefest of introductions and then have you take it away. So thank you for joining us, and I appreciate you speaking on this topic.
Well, Ken, I want to thank you very, very much for inviting me, and I appreciate your letting the audience know that I have just been delighted to be working with NAMI over all these years. I really appreciate my collaboration with Sue Abderholden here in Minnesota. I thought I'd let you know that Sue has been so nice for us to have annual NAMI research dinners for the university and NAMI to collaborate, and I believe they have been very informative and have been a lot of fun for me. So I can't thank you enough for asking me to join in on this NAMI call this morning. Audience then, I have made some comments that I would like to talk about. We have about 15 or 20 minutes for me to make these comments, and I would want to make sure to invite anybody that has any questions in this area of the stages of schizophrenia and the aims to reduce the duration of untreated psychosis has been called DUP. I think all of us who are on this phone line from NAMI and those of us in our schizophrenia program here in the Department of Psychiatry realize the significance of psychotic illnesses. We know schizophrenia is prevalent in the United States with a 1% prevalence rate. We know that there are a number of different issues related not only to the psychotic symptoms but to the health of the people who have this illness. And as we're also talking about duration of untreated psychosis, we're probably even addressing some of the issues brought up by the APA of looking at the domains of psychosis, because it's not restricted only to schizophrenia. And we know there are a number of young people who are developing bipolar disorder with psychotic symptoms, and it does also sometimes occur with depression as well. Well, my experience over the years of being engaged and working in the area of schizophrenia is that in the past, our field was not engaged in trying to recognize schizophrenia early. I think a number of more dynamically oriented psychiatrists would want to get to know the person, and they may even be in therapy for a couple of years before getting treatment for their schizophrenia. However, starting with a number of different studies around the world, there has been an aim to reduce the duration of untreated psychosis and to make sure that we work together to have an appropriate approach to these young people. Now, I have been very interested in the development of our program. Most recently, have even gotten some information from the National Institute of Mental Health about the impact of this first episode psychosis. And I'd like to note that the National Institute of Mental Health has indicated that there are probably 100,000 first episode patients who develop first episode psychosis each year. I think one of the other things that is important for us to know is that this early phase or this onset of schizophrenia starts picking up actually in early teenage years. And some of you may really be aware that there are people who might be 14 and 15 years old coming down with a psychotic episode. Epidemiology studies done in Europe have clearly indicated that the average age of onset in males is probably 21 years old, and for females is probably 3 or 4 years later, or 25. But we do have to remember when we look at papers like that, that that's the average age of onset. And so I went back and looked at an older epidemiology study looking at people coming to the emergency room in New York City. And in that article, it turns out that 40% of the young men had developed the diagnosis of schizophrenia before they were even age 19. Well, this means that we have to be working with our child and adolescent psychiatrists as well as those interested in engaging in treating psychosis. So I wanted you to have a bit of that background. Well, I think there have been a number of sites in the United States, John Kane's work at Long Island Hospital, the work out at UCLA with Steve Martyr, Keith Nectarline, etc. But interestingly enough, recent data from the National Institute of Mental Health has indicated that currently the length of time from the onset of psychosis to treatment, or the duration of untreated psychosis, right now in the United States is 78 weeks, or essentially a year and a half. We are very concerned about whether we're getting the information out to our primary care doctors and our pediatricians, whether there may be some instances where they may not necessarily recognize some of the symptoms of psychosis. And as you may be aware, also the aim now to make an intervention in the prodromal patients as well. But I did want everybody to know that there is still a very significant challenge, and obviously those schizophrenia programs and first episode programs around the country can partner closely with NAMI. I'd like to note that the United States has probably been a little bit behind other countries such as Australia, Canada, and England, who have had some very active first episode programs for a number of years. And actually, for those of us very interested in the first episode work, being at meetings where we hear the presentations from people like Dr. Patrick McGorry from Melbourne, who started the early episode symposium that he's been doing for many years now, we are beginning to understand what are these ways to approach and engage these young people. It turns out that right now, a lot of us in the country are following up on a study that Dr. John Kane worked on with the National Institute of Mental Health called the RAISE study, and how in looking at 400 patients in sites around the country that we are learning that there is an appropriate approach to beginning with a low dose of a second-generation antipsychotic medicine, that the talking therapies and engagement with the young person is probably best at this stage of the illness with a cognitive behavior therapy approach, that occupational therapy is also very useful for these young people to help them get re-engaged. And one of the things we're doing here at the University of Minnesota is engaging with our University Disabilities Office. I'm really pleased to say that we now have had a number of first episode young people who have gotten their bachelor's degree after starting in our first episode program. Well, I thought to myself, this is a NAMI function, and so I wanted to make sure to talk about our first episode family psychoeducation approach. You probably are aware of those. You may have those where you're working, but I thought I'd describe how Dr. Michael O'Sullivan, who is our attending psychiatrist for our psychosis ward here at the University of Minnesota, has started a family psychoeducation group. He begins this with an introduction in the first week and then hands out a curriculum for the next 8 weeks. The parents that have been going to this have said that it has been so useful for them to learn about what are the issues about schizophrenia, what are some of the neurophysiologic studies, what are the talking therapies that benefit, what are the genetic backgrounds, etc. And they have said they really, really enjoy the psychoeducation groups. What they note and what I've noticed over the years working in the area of the family groups is they also say that when their son or daughter came down with the psychotic illness, that they felt very isolated. And this was not something they felt they could talk about with their friends. And so with this first episode group, not only did they get information that they say is extremely helpful to them, but they have an opportunity to talk with the other parents in the group and maybe even learn some practical issues that the moms and dads of other people are doing. This has led then, after they finished up with the family psychoeducation group, for the formation of groups that get together for support thereafter. And of course, Minnesota NAMI does groups like this, and I'm sure from all the other states I heard from, there are those kinds of support groups as well. I think this is an extremely important part of the intervention in first episode. We know from family therapy studies over, say, the last 30 years that this sort of engagement does have a significant impact on the reduction of relapse, and it can probably also help substantially with adherence to the treatment. Ken, I thought I might say something also about how over the years I've done a substantial amount of research to try to understand the issues of the pathophysiology of first episode illness. Back when I started this work, it actually was quite controversial, and I worked with Dr. Dan Weinberger on how to be measuring brain imaging. Our site and also Jeff Lieberman's work in first episode, John Kane's as well, we have all demonstrated that in the early phases of schizophrenia that the brain imaging is similar to that of adults who have schizophrenia. Furthermore, we did the first study in teenagers to assess cognition, and we found out that there were cognitive difficulties, such as sustained attention, that are already present at the outset of the illness. And I'm going to make a few comments later about how we're approaching that. But in the talk this morning, in working with you all, I wanted to let you know there is research that does clearly demonstrate the continuity of some of the findings that are seen in adult patients with schizophrenia. So it does sort of prove that is the continuity of this illness. I'd like to move on to the issue of treatment. I mentioned that from the RAISE study about reducing the duration of untreated psychosis and not only recognizing but appropriately treating, that the medication treatment for adolescents and young adults, as I'm sure you all know, is very, very challenging. Back before the second generation medicines came out, there were very few studies about how to treat these young people, but the ones that came out noted that for teenagers and young adults, they were very, very sensitive to the movement disorder side effects. They might have muscle spasms, they may have substantial tremor, and some publication in the American Journal of Psychiatry during the 1980s said they didn't think they could even get to an appropriate dose of medicine because of the side effects. This was very problematic also because it certainly didn't lead to any adherence to the medications. With the second generation antipsychotic medications coming out, a number of people felt there'd be a reduction in the movement disorder side effects, but I think everyone is aware, especially from the work of Dr. Correll at Long Island Jewish Hospital, who is a child psychiatrist and has published work about how the adolescent and young adult first episode patients have substantial metabolic side effects. And he has reported on a case series about the very significant weight gains with medicines such as olanzapine and risperidone. I did some work also with Dr. Robert Findling, who's now at Johns Hopkins. We did a case series of teenagers using olanzapine, and amazingly, they gained 13 pounds in the first 8 weeks. This is really a significant issue, and a number of sites around the country and taking a look at treating young people are making sure to monitor the medication side effects and to examine using the medications, which is part of the treatment plan, to diminish metabolic side effects as much as possible. I think that I would like to comment that I mentioned I had done studies with brain imaging and that I had done studies with neurocognitive testing, and many of you may have heard that there is now emerging the neurocognitive remediation approach to people with psychotic disorders. This is using computerized programs such as Lumosity, and we have started this in our day treatment program for the first episode young people. What we're finding is they feel that their cognition is getting better. I'm sorry I can't report on how much statistically, as our sample's not large enough yet, but the one thing that I've really noticed that is really a neat thing is because these young people are working on the computers, they usually come to this session right on time or even early. They have really enjoyed it, and I think we'll be able to start communicating soon about how some of these cognitive areas improve. Cognitive areas improved is really going to be an important part of working with these young people because it will help them socially and it will help them in getting back to school or getting back to work. What I'd like to do in conclusion, taking a look at the clock on my desk and seeing that I'm probably already at my 20-minute point, is that by engaging these young people early, the studies have shown that it really does improve the outcome. Secondly, as we're taking a look at reducing the duration of untreated psychosis, I know that we want to include and work very hard to reduce the stigma of this illness because I believe that may be part of why people do not come. And then lastly, I'd like to let you know that President Obama has led to an allocation of federal money added to the state's health for reducing the duration of untreated psychosis. And then just in the last week, we have found that SAMHSA has put out an RFA and will make an award to 16 sites in the United States to enhance the reduction of the duration of untreated psychosis. For this government support for reducing DUP and for working with SAMHSA, I think the first episode programs really is going to need to engage in their local NAMI programs so we can get the word out and we can support these people. Ken, I think I'm done, and I want to thank you so much for inviting me, and if people have any questions or comments, I'm delighted to hear them.
Dr. Schulz, thank you so much. This is an important area in our field, and NAMI can really be part of the continued progression of this. So let's open it up for questions. We go till noon. It's a little chaotic, but just be patient. We usually get to just about every question. So first person just want to see where they're from and just sing out a question.
I'm Becky from Nashville.
Go ahead.
I have one comment and one question, a couple questions. Number one is on the weight gain. I was fortunate that my son also, he gained 100 pounds the first year on Zyprexa. And he got a, what do you call it? Anyway, he had a seizure, and whatever kind of doctor handles that seizure, hang on, I'm sorry. Whatever doctor handles that seizure, neurologist, I guess it is, he gave Michael, he says, I can't fix the seizure, but I can fix the weight gain. And he gave him a product called Zonisamide, and Michael lost 100 pounds that year and has kept it off ever since.
Well, I'm very glad to hear that. And I want to let you know that a number of sites are doing research studies to see for the medications that could be reducing psychosis but not be, causing the weight gain, that there are studies going on. So I'm glad to hear that that this neurologist added the medicine so that he reduced his weight. Glad to hear that.
A seizure medicine, and I wish more people were able to use it because it had no side effects on him. He said that it was going to retrain the stomach and the brain to communicate, and that's exactly what it did. And then after he quit the medicine, he continued to have the weight stay off.
Did you spell the medicine? The name of the medicine? I didn't hear it.
I think it's ZONO. I'll get it in a second. And the other question I had was, what is involved in cognitive behavioral therapy? I'd heard that was really big for schizophrenia. My son's 35-year-old with schizophrenia. But I haven't found anybody around Nashville that will use it for a schizophrenia patient. They said they only do it with brain damaged people. So suggestions on what that therapy would entail.
So the way that we began the program here, and there are a group of programs around the country doing this for adults with schizophrenia that have had the illness for some time. A lot of this work started out at Yale. So a number of people are now using the program Lumosity that we hear advertised on TV. I think that there is enough literature now on the cognitive remediation that if you were to ask your clinic if they would be able to do it, they should be able to talk to you. And if not, if Ken, you don't mind, could I give my email address out?
Of course, it's fabulous.
Okay, so I'd be happy to take your email, and we have psychologists running our program. So my email is SCS, that's kind of Sam, Charlie, Sam, at umn.edu. And I'd be happy to hear from you and see how we can assist in this.
Okay, and I'm sorry, I didn't get your last name. What's your last name?
My last name is Schulz, S-C-H-U-L-Z. I'm Charles Schulz. I live in Minnesota, but I don't do peanuts. Hey,
my daughter just married the cartoonist for the Nancy and Sluggo cartoon, so that was very appropriate for you to say that. I would have thought that.
Good fun.
Anyway, one last question is, my son's psychiatrist told me just this year, he's been sick for 10 or 15 years, that she really believes he has a delusional disorder on top of the schizophrenia, and then she felt it wouldn't do him any good to really see a psychologist or anything because of the delusions are so severe. Is there medication for that, or is where do we stand with that? Where do you stand with that idea?
Hi.
I think that's a very good point, and let me comment that when I do work on our wards and we have people who have received the diagnosis of schizophrenia, but they're in this domain of delusional disorder, oftentimes these delusions can be extremely complex, and a number of our patients have extended notebooks on all of the background that they're writing down about these things. And I've not found the delusional disorder to be the patients seem to calm down when we use their medications, but it's not as if the delusion necessarily goes away. And so what I've found is that actually a cognitive behavior therapy or a talking therapy to try to discuss this can help, but it is a challenging aspect of the psychotic illnesses.
Okay, so, okay, thank you very much.
No, the pleasure's mine. Good questions.
Another question for Dr. Charles Schulz.
I have another one.
Okay. Let's see if anybody else has a shot. Then we'll come back to you if not. All right?
Okay.
We'll get all your questions.
I have a question.
Go ahead.
I'm Cheryl. I'm from Connecticut. Where do you stand? I mean, given the gross side effects of these antipsychotics, if you have an individual who has been very stable on an antipsychotic for a 3-year period, no incidents, 4-year period, where are you with reducing dosage?
Well, I think this is a very good question, and I was just at the Schizophrenia International Research Society meeting, and this was discussed in one of the symposium. If you don't mind, I'll give a little bit of a longer answer. One of the issues in first episode work has been that when a young person and their parents come in and the doctor says, well, we need to use an antipsychotic medication, what we found is that as you may be aware, over maybe the first year, a lot of times the young person may feel better and stop the medicine because then they say to themselves, I'm not sick. And then sometimes moms and dads are not excited about their kids taking the medications. What we're finding is that when a person does stop taking their medicine in the first couple years of their treatment, that unfortunately almost all of them do relapse, not everybody, many relapse, and that it takes longer for them to respond with their second and third interventions. So I'm trying to say try to be careful, but if you all work with NAMI, I know you probably talk with moms and dads whose son or daughter is going through their first treatment. I think what other thing you're describing is what's called the lowest effective dose. And I think that's an important thing to speak with your child's doctor vis-a-vis the trying to see if they might be able to take a lower dose than the one they started with or helped. Some sites are also talking about having a very, very good discussion about lowering the dose or where there's a significant demand of stopping it so that people will understand the risk of relapse and to make sure to reconnect as soon as possible if some symptoms return. Does that address your question, or do you have a follow-up?
I guess it's still to me a crapshoot because he's achieved a degree of stability, and God knows we don't want to go backwards, nor do we want to go through having a medication that is now really working not work again, or something along that line. But I do question the fact that he's still on the same dose that he was on with this, pretty bad psychotic episode. So, I guess, I'm being told not to tempt fate is basically where, and as his mom, he's had significant weight gain and some of that metabolic stuff. So I'm like, wow. But then I'm also told that it doesn't matter whether it's a small amount of this medication or a larger amount, you're going to end up in the same place if you're susceptible to that metabolic situation.
I do hear what you're saying, and I think I have to agree. I think you could have a discussion with your doctor about whether there may be a bit of a step down of the dose, and we're not talking all that specifically about which medicine at which number of milligrams, but it is appropriate to discuss with him the lowest effective dose needed.
Okay.
Yeah, so you're now into the post-scientific study art of clinical work. This is Dr. Ken. And, really it requires shared decision-making, really thinking through what are the risks and benefits of each path before me, right? Some people need medicines for decades. Some people don't. We don't understand the biology enough to know who's in which category. So the questions are, if you're going to reduce the dose, so I work in a first episode of Psychosis clinic on a half day a week as well. I have these conversations all the time. Typically the young man comes to me and says, I want to get off my meds. I've been doing great for 3 years, and I'm back in community college. And, of course, this is the classic dilemma because, all the medicines have side effects of different varieties. Not all of them cause weight gain, but they all have something. And, the conversation, I usually say, well, let's bring your family in and have a collaborative problem solve about this. Like, what are the risks? Would you notice it if the symptoms recurred? Sometimes I found that the young people have forgotten how ill they were when they were ill.
Yeah.
And so I have them look at the records of when they were in the hospital. I said, this is, the risk that you're taking if you stop the medicines. But if they are their own guardians, I say, if you really want to stop your medicine and your family's willing to support you through it, we'll do it very slowly as long as you promise to learn from this. That is to say, if you get rehospitalized or you get very ill or you drop out of school, if you're willing to reconsider this, option and learn from it. So that's the level, I think, of the science, which is to say we don't know how long a person needs to take these medicines. I don't say to people you need to take this medicine the rest of your life because I don't think we're that good. Like if you look at the long-term literature for a program like, an illness process like schizophrenia, many people do well in their 40s and 50s, many off of medicine. So it's very humbling. Would you agree, Dr. Schulz, with everything I've just said?
Absolutely, Ken, and I really appreciate your practical comments on how you're collaborative in working with the families, and I am hopeful that the people on the phone have doctors who are that nice as you.
Well, I think the idea is, the families love them long after my session ends. And the family, knows and often provides the support and resources that are enabling the young man's recovery, young woman's recovery. And so, it's just a collaborative thing. And typically the family doesn't want to tolerate any of the risk, right? But I think it's important to have the conversation because it's the person and their body that are experiencing the side effects. So it's a complex integration of different perspectives. And then, of course, if their own guardian in Massachusetts, they can make their own decisions. I say, how much do you want to take a chance? You're doing, your 2 years of community college, you have a 3.5, you're ready to transfer to UMass Boston as a school we use a lot for people who are getting out of community college. You're ready to transfer, you're going to take it up a notch. You might actually be able to become a nurse or something like that. Something in healthcare is what you say you want to do because you've lived with this experience. So it's a very interesting question. And sometimes we reduce the dose. If they're on clozapine, which is, of course, the best medicine for treatment refractory psychosis and is the only medicine of the antipsychotic varieties that have been shown to reduce the outcome of suicide. But
actually,
it's
that
also,
is the med my son is on.
Yes, but it's also a toxic medicine with many side effects. I frame it to people as psychiatric chemotherapy. And, if you have a serious illness, you take chemotherapy. But, you can get a blood level on that is my point. So if he wants to have a conversation with his doctor, you could say you have no symptoms, but you've gained X pounds on this level, blood level. And then if we reduced it by 25 milligrams over 3 months or 6 months, we could look at your blood level. Anyway, that's a long answer on my part, but I just wanted to share that because this dilemma comes up with me, I'm going to say every Thursday afternoon at the clinic.
There you go.
There's some variation on it. All right, another question for Dr. Charles Schulz.
Yes, hello, this is Marissa from Connecticut. I had a question. I know that, my son has schizophrenia, and he, was diagnosed when he was 17 and a half. He's 23 now. And, I know it's a psychotic illness, but he suffers from negative symptoms, and we don't have any medications for negative symptoms. And I know that by going to the, Yale Neuroscience annual conference, I've heard that they're working on some things, but how do we advocate for better treatment? Because, sometimes persons with schizophrenia, they suffer from negative symptoms, and there isn't anything we can do about it.
Well, a few things that I might say about this is, first, thanks for bringing this up. I want to let you know that in our field we are now having a number of doctors explore how to treat domains. And you may be aware that there are studies in which people are trying to see if there is a medication or a therapy that can assist with domains such as either negative symptoms, cognitive symptoms, social cognition as well. Some of our patients will sometimes have difficulty being able to talk with a person and look in their face while they're talking. I'm sorry to have to say that you're correct. There's not a specific medicine that's approved for negative symptoms of schizophrenia. Some people will say that the cognitive behavior therapies that are probably have been more tested in Europe than in the United States are very useful, and I don't know if your child is receiving that or not, but that could be something to be discussed. I know that there are a number of studies going on about medicines that work in different parts of the brain than the antipsychotic medications, and that hopefully as some of these come out, we'll be able to then start talking about how to help negative symptoms.
Because, I thought that I'm sorry, I was just going to add, this is Martha from Connecticut, I was just going to add that, negative symptoms are part of the illness, and it seems like all we have is those psychotropic medications, and unfortunately, I guess we just have to keep working on advocating, for better treatment for our children and, for medications that will help with the entire illness, not just part of it.
That you have said that in a very very clear way. I really appreciate that, and I wish I had the background to be able to say, oh, here is this new treatment that works for this. We're not quite there yet, but I know that a number of sites are working to see what they can do.
Thank you.
Yeah, no, thank you for being on the call today.
Dr. Stephen Martyr of UCLA did a call on negative symptoms on the Friday call perhaps a year ago, and I think that is available through www.nami.org/askthedoctor. And he did basically reiterate our frustrations around negative symptom compounds, but he is an expert on negative symptoms particularly. So if that's of interest to you.
Thank you.
Another question.
Yes, Dr. Schulz. My son has schizoaffective, or sometimes they vary the diagnosis, but he's a pretty complex case. And one thing that a new psychiatrist, he's in a state facility right now, but they added a beta blocker, and it made tremendous difference on top of all the antipsychotic meds, and it's really shown. He's showing amazing progress, working, going to school within the hospital system, but that was just with the addition of a beta blocker in addition to his Invega and lithium and a whole bunch of other things.
Well, thank you very much for bringing that up, and I'm delighted to hear with that improvement. Interestingly enough, beta blockers were first tested in the area of schizophrenia during the 1970s, and it does turn out that there were mixed findings. There were some initial positive results and then some others that didn't separate from placebo. We know that the beta blockers do act in a different way than the antipsychotics or lithium, acts in the norepinephrine receptors in the brain. And so I'm very pleased to hear that that you and the doctor worked together and gave a try for this. I think that sounds very good.
Thank you.
Sure. No, and best wishes.
Thank you.
Hi.
Dr. Schulz, one quick question for you. Hopefully, can you hear me?
Yes, I can.
Okay, great. I once read an article in the Journal of Medicine about how some doctors, they had done a trial using metformin to reduce glucose to offset the effects of some of the antipsychotics. And that particular article was enough to get my doctor to try metformin for my son, and it worked to just keep his weight steady from that point. So I'm curious, since then, have you seen any further studies on the use of metformin, which is, a common medication for diabetics, to offset the impacts from the antipsychotics?
This is a very good question, and this did come up in our last Friday's schizophrenia group meeting here at the University of Minnesota, and there are some recent papers that have come out now that have taken a look at all the different metformin studies, and it's reaching the point now where people are discussing maybe a more frequent use of the metformin. I think the articles that have taken a look at the different studies are saying that the side effects are not substantial, and that there is a significant possibility of the weight reduction. So that's at our program here, and in my reviewing the literature, there are now recent studies that have been examining the clinical trials that are going in the direction you just described.
Great.
And so I think that's, I'm glad to hear that is working.
Yeah, my concern is always that, a doctor changes and all of a sudden we have to validate the use of it again. And so I'm encouraged to know that it's still a conversation, and perhaps I could again, find a paper or find an article to justify a trial of metformin if we needed to. I mean, he uses it real successfully now. Like I said,
Dr. Schulz, would you be
future.
Dr. Schulz, I'm sorry, I didn't mean to talk over you. Would you be willing to send the summary or review paper to our staffer, Emily, who can post it to attach with this call?
Absolutely.
Great. Emily, you're on the call, right?
Yes,
Emily's
I am.
rock steady, always there. So if you would just do that, that was a nice service, and then, this family member has the information when the doctor turns over. But I think you're right. I think this is a new, novel idea which is catching on.
Well,
you may not
okay,
get that
and you
much
and I are on the same page again, Ken. Emily, I know you've emailed me before, so if you just send me that, I'll get this recent article back to you. Does anybody else have a question?
I have a question. Hi, this is Antoinette.
Hi, Antoinette. Where are you from?
Illinois.
Okay, well, that's where I grew up, so happy to hear from you.
Thank you. How can you get a child that's 19 that's been off of her medications for at least 4 years? How can you get her to take medications or to talk to you?
I will start with this by saying that we did discuss some domains such as negative symptoms. Dr. Martyr also works in social cognition, but we have not brought up today, and I probably should have included the issue that some of our young patients are not insightful that they have an illness. And I think we know of Dr. Javier Amador, who does a lot of work in this area, and he has published books about how to try to, in a psychotherapeutic way, work with the young person who only may not take their medicine, but may say, I don't need to take the medicine because I don't have a problem. So I am thinking this is probably one of the reasons why she wouldn't be taking her medicine is a lack of insight into the illness. Does that seem to fit with what you've noticed?
Right. She doesn't think she has an illness. She's also been in residential treatment for over 3 years, and they've not really helped her when she would manic. She's got PTSD, learning disability, bipolar, and her PTSD is sexual, so she goes after, for her to be able to
be sexually manic, she knows that her medication would stop her from doing that.
So this is Dr. Ken. I just want to say this presents a tremendous challenge for family members, and that Dr. Amador, A-M-A-D-O-R, has been on the Friday call, and he is a great resource for this particular problem when a person cannot appreciate that they are ill. So if you look at the Friday call list, Dr. Amador has been on this call, but also has his own website. So it's dramador.com, and he has a very compassionate way to approach this problem, which is really rooted in the biology of the illness process. It's not psychological denial in most cases. We have time for one or two more questions. So go ahead.
Hello, my name. Oh, okay. Hi, my name is Lisa. Oh, sorry. Go ahead.
This is from Connecticut. My son had been on clozapine and doing well, but because of sleepiness, he was switched on to Latuda. But after some time, he had stomach pain, and that stomach pain has been going on off and on. Is that due to anxiety? Is that due to Latuda? But for over a year, they had been trying to find what is the cause, and nobody has really found out. Do you have any research on Latuda causing stomach pain or anxiety causing stomach pain? Do you know anything?
We know that Latuda is a newer medication, and I have heard that it does lead to some stomach pain and problems, and that it's not the only second-generation antipsychotic that does that. We also know that risperidone can be in that ballpark as well. After having been on clozapine, has the Latuda managed his symptoms of psychosis?
Yes, actually he's doing well in school, but because of the stomach pain, he doesn't do a lot more other than the very little he needs to do.
Okay. Well, and if Dr. Duckworth has a comment on this, I think you could discuss with the doctor that if he is doing well on Latuda after having been on clozapine, but is having the side effect of the stomach pain, is the doctor could consider whether there was another medication, whether it might be the medication aripiprazole or whether it might be another second-generation agent that he could take that might not cause the stomach pain.
Okay, they changed and gave anxiety medication, and it seems some anxiety medication was helping, but he's on Latuda and clozapine and then anxiety medication, but off and on this stomach pain comes and he's immobilized.
So you're also telling me
this morning for morning recess. Thank you.
He is still taking his clozapine?
Yes.
Okay, I think you could even talk with the doctor about whether he needs the added Latuda or not. That would be another question for him.
Okay.
Thank you for the question.
Yeah, one of the reasons people get on a medicine in addition to clozapine, in my experience, is to reduce the dose of clozapine,
right?
Which often has a very good effect, but often has side effects.
Yeah, that was the reason because of the sleepiness, and he couldn't do graduate level work. He wanted reduced dosage, but that caused stomach pain.
Dr. Duckworth, time for one more question for Dr. Schulz.
Hi, my name is Lisa and I'm from Pennsylvania. In the beginning of the call, you had you had made reference to borderline personality disorder, and I just have a quick question because I'm trying to find resources. My daughter is 14, and she's showing symptoms of this, and when she has her behaviors, they're big behaviors, and so I'm really trying hard to move forward and try to catch anything before she hits 18. And I feel like my options are so much more limited.
Dr. Schulz is an expert on this topic, but Dr. Ken's going to jump in. Last month, I just did a call on intervening with teenagers who have borderline personality disorder. So that should be on our website with any luck.
Okay.
And if not, I would look up NEA BPD, the National Education Association for Borderline Personality Disorder. They have a fabulous series of resources.
Okay.
And now we'll let the expert answer. Go ahead, Dr. Schulz.
Well, Dr. Duckworth, thanks for calling me an expert. Very nice of you. And I really appreciate your bringing this up because just as first episode, schizophrenia was controversial in decades past, in psychiatry in the United States, there was an idea that borderline personality disorder could not occur in teenagers. And recent research from actually a number of countries around the world are showing that, yes, indeed, the diagnosis can occur during teenage years. There are even now specific adolescent dialectical behavior therapy programs for the young people. And so your recognition of this and wanting to get your daughter into treatment, very good idea. And I think and hope by maybe taking a look at the website that Dr. Duckworth noted that you would be able to have her begin the dialectical behavior therapy.
Yes, I've actually looked into that. I've bought her a workbook, and I've been trying to get her to work with me on it, but she's 14 and likes to fight me on it, which is pretty standard. Right now she's actually inpatient her fourth stay, and so like I said, I'm really eager to, because the doctors are very cautious in giving her any sort of a diagnosis, which I absolutely understand. However, I feel that ignoring the elephant in the room is only going to agitate the circumstance and not going to be able to really allow her to move forward.
What's interesting, this is Dr. Ken, some people, get relief when they're given the diagnosis. Aha, I have something that's treatable that explains it. But sometimes the doctors are reluctant to call it that, when a person is, still forming a personality. But either way, self-management strategies to reduce self-harm, ways to modulate and regulate emotion are themes, even if you can't get the doctors to call it what it likely will turn out to be.
Okay.
The strategies can still be employed either way. So I'd like to ask everyone now at the end of our call to undo their mute button, to push *6 and sing out a NAMI thank you to Dr. Charles Schulz, who gave us an hour of his time. He's a very busy lad doing research and helping people at the University of Minnesota, and he gave us an hour of his time. And I just want you all to yell out a thank you.
Thank you.
This was very helpful.
Thank you, Dr. Schulz. We're so lucky to have you as such a great friend in NAMI. All right, stay tuned for the next Friday call, and all the best, everyone.
Thank you very much, Dr. Duckworth, for inviting me. It was a total pleasure.
Thanks to Emily for running the show.
Thanks, Emily.
Thank you, Emily.
Yay.
You're welcome. Thanks, everyone. Bye-bye.
Bye.
Happy weekend.
Thank you.